Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. Welcome back especially to our monthly edition of Show Me the Science. Think of how much time, money, and energy has been spent fighting COVID-19. A global scientific effort resulted in new vaccines and new treatments, all on an accelerated emergency timeline. Now compare all of that to the time, money, and energy being spent on long COVID, or should we say the lack of time, money, and energy? Today, we're meeting with two outstanding physicians who are helping us define what long COVID means, and we're diving into recently published research in the Journal of the American Medical Association that analyzed the symptoms of people living with long COVID. But before we speak with those good folks, today, we're going to highlight on our health system doctors who are working at the Chiefs training camp. Alan Van Zant is live right now in St. Joe, Missouri. Good morning, Alan.
Hey, good morning, Dr. Stites, here at Spratt Stadium, where 11 months out of the year, home to the Missouri Western Griffin football team, but for a few weeks each summer, home of the Kansas City Chiefs, the Super Bowl winning Kansas City Chiefs. They're ready to run it back one more time here. It's a beautiful morning, actually. Videographer Cliff Irwin and I were playing amateur meteorologists. We were looking at the radar. It had been drizzly up here for quite a while this morning, but it is clearing off and practice set to begin at 9:15 this morning. I'll have Cliff turn. We've got fans already waiting to come in this morning, and that's been part of the story here so far this year. Some of the record-setting attendance, crowds that have come for these preseason practices here in St. Joseph, and why not? When you get to see all the players up close and personal, get to see head coach Andy Reid, it's a lot of fun up here for anyone who wants to come up to a practice. And if you haven't been up here for training camp, it's really easy access. The highway, the university right off I-29 here, and of course, part of the team is our physicians. We are, of course, the healthcare provider to the Kansas City Chiefs, and our physicians play an integral part of the players' success during preseason camp and the season as well. They're watching players who are coming back from injury, making sure that they are okay on the field, and of course, watching for heat-related illness. That's been another part of the story of this camp so far, is if it hasn't been extremely hot during camp, we've had severe weather, severe thunderstorms, and some days both in the same day. So the players are monitoring, or the physicians are monitoring the players as they're going through their practices. We are going to talk with some of our physicians later this morning. We'll get some of those comments on a future morning medical update, but it will be interesting to hear from them how camp has progressed so far this season. Now, looking at the Chiefs season, camp is here until Thursday, August 17th, and then we've got the first preseason game, and then we've got the first regular season game, which comes up Thursday, September 7th. That will be at GEHA Field at Arrowhead. That's going to be a lot of fun. Now, the first preseason game is in less than 2 weeks. That is the 13th of August, coming into the last week of camp here. So it's going to be a lot of fun this morning here, seeing the players up close and personal as they are the defending Super Bowl champions. That's a lot of fun to say. From Missouri Western here, Chiefs camp, Dr. Stites, back to you.
Thanks, Alan. And just to say, if anything happens to those players for the rest of the week, you're to blame. And so to make sure everybody stays safe and happy up there. All right, joining me here in the studio
far away from them.
Yeah, is Dr. Mario Castro. He is a pulmonologist here at the health system. Unfortunately for him, he's my part-time boss because I have to talk to him about how I do pulmonary medicine. And one of the best parts about him, though, he's also on the academic side. He's a vice chair of clinical and translational research here at the Medical Center. Good morning, Dr. Castro.
Good morning, Steve.
How are you, sir?
Nice to be here.
Thank you. All right, we're also joined by Dr. Clifford Rosen. Dr. Rosen is an endocrinologist, an associate editor at the New England Journal of Medicine, and the director of clinical translational research at the Maine Maine Medical Center Research Institute. Good morning, Dr. Rosen.
Good morning, Steve, and good morning, Mario. And I'm glad to see the Chiefs are working out, but the Patriots are going to win this year.
I'm sorry to tell you, Dr. Rosen, I know you're an outstanding physician, Patriots time has passed. Just saying. Tom Brady retired. Thanks God for that. All right, so we're also going to be hearing from Dr. Dana Hawkinson, a.k.a. Doc Hawk. He is our Medical Director of Infection Prevention and Control. Hawk, welcome back, of course. All right, Dr. Castro, let's talk with you about this study that you have recently co-authored. It was part of the NIH Recover Initiative. This was an observational cohort study at a cohort of 9,000 people who had COVID. And you followed them while they went about their normal lives. You wanted to see what symptoms, if any, people reported after 6 months. Talk to us about what you found.
Well, in this study of over 9,000 patients, we compared those patients that had acute COVID infection within 30 days of entering the study to those patients that weren't infected. And what we were trying to do is understand what are the symptoms us as physicians can utilize to think about making the diagnosis of long COVID. And we found over 200 symptoms reported in our patients, Steve. And it was quite striking that some more frequent, the top 12 that'll be listed here, symptoms came out as being really helpful in making that diagnosis of asthma. I'm sorry, diagnosis of COVID. My other scientific hat, making the diagnosis of COVID. And I think it's important because we as physicians, we sometimes hear these symptoms like losing your taste or smell, and we've not really seen that very often before. And so some of these are really unique symptoms that help us kind of clue us into, hey, this patient may have some symptoms of long COVID after that infection. And when we think about the impact of this, it's estimated around 700 million people worldwide have had COVID. And if we think about 10% of them are experiencing long COVID symptoms, even out to 6 months, as in this study. That's a lot of people. And so this is a huge public health problem that we need to put a lot of attention to.
It is a public health problem, and man, that is a lot of folks. Dr. Rosen, is the 12-month symptom too broad? How does a broader definition need to be to include everybody?
That's a great question, and it's controversial. So the 12 were ranked according to the frequency of complaints at the 6-month time point. But I think some people, including a lot of survivors of COVID who have long COVID, felt that it was very narrow and that you had to include every single symptom because some people are excluded if it's not named as a symptom, but it could be related to COVID. And this is the underlying problem with this disorder, is that it comes in many forms, many shapes, and many frequencies. And so if we think too narrowly, it could hurt people in terms of disability insurance and in terms of recognition from their primary physician about the diagnosis. So I think they hit it about right, and it's scientifically based. But in the article and among the authors, it was clear that we caution everybody that this is only the beginning, and this is a work in progress. It really is something that's going to be amended. It's a living document and will continue to be as we refine our science.
It's got to be especially hard for people to fully understand that, because, and let me ask this, is it a continuation of initial symptoms, or is it the onset of new symptoms, combination of both? Dr. Rosen, what's it like?
Yeah, that's great. That's a great question. So I think in many cases, it's a continuation of symptoms, but some individuals, especially mild or asymptomatic people, will suddenly develop brain fog and fatigue and post-exertional fatigue 3 to 6 weeks after their infection, when they've been very okay and or not even feeling they had the infection. So I think it could be a combination of both. So one of the interesting things, and I'm interested in Mario's comments about this as well, is that we're beginning to see in some of our subjects beyond 6 months that some of those symptoms do go away. And trying to understand who those people who have persistent symptoms among the 10% who are infected and then go on to develop long COVID type symptoms, which ones of those individuals are going to continue a long-term course of symptomatology.
And here's a question I've been wanting to ask you, because I have a patient I wanted to ask you two about, because I got you both right here in your corner for a minute. But, do people with underlying medical disorders have a harder time with the recovery from long COVID? And what prompted that is of a patient who I follow with, I do cystic fibrosis, by the way. I have a patient who had mononucleosis. 3 months in, was actually starting to feel a lot better, has pretty normal lung function, fortunately for this patient, and then got COVID. And now, 3 months after that, is just really wiped out. So I'm just saying, gosh, there must be a sort of the double whammy effect here.
Yeah,
that's very scientific, double whammy syndrome.
I think the long COVID, one of the most important things that we've seen is this comorbidities. The underlying comorbidity can really drive a lot of the severity of that disease and the persistence of the symptoms, and puts them at increased risk. And maybe that's related to some of the immune dysfunction that we've seen as related to COVID. I was thinking about Cliff's comment earlier. One of the things that we think is going on, and we're going to tackle this with one of the treatment trials, is that this virus tends to persist in our body. It's kind of like the mononucleosis, where it can last for weeks and weeks. And so this is something that we're starting to learn, that this virus can hide out in your body, in a sense, for weeks to months after that initial infection.
So how many COVID patients or long COVID patients are out there?
Well, as I mentioned, there's probably, worldwide 700 million, and if we estimate that, 10% of that's 70 million people worldwide with long COVID, and that, I think that's actually a relatively conservative estimate. It depends on how many of those symptoms do you have to have, and what time period. Fortunately, the majority of those patients we now know their symptoms are going to decrease over time and go away by the end of a year. We also know that those that got vaccinated are less likely to have long COVID. So we know at least two things that are kind of bright shining lights: that the vaccine did help us decrease the incidence of long COVID, and that the majority of these patients are going to recover.
Yeah, that's a really important statistic, that bit about having the majority and having people to look forward to. When does long COVID start, folks? Is it 3 months, 6 months? I kind of hear both out there. And is it at 3 months if you're still sick? Is it really long COVID, or just continuation of how you already felt? So help me understand what it is and what it isn't.
Well, I think that the WHO gives it a 3-month time window, and then the onset of a symptom that they hadn't had before. I think it still needs refinement. Some people say it's 8 weeks or 2 months, and some say 3 months. And I think when we think about it in simplistic terms, new symptoms that develop in an interval after the acute infection is over with is likely the most accurate way to approach long COVID. And in fact, the ICD code U09.9 states that anything beyond 3 months, any one of the 12 symptoms or other symptoms that are new, can be labeled as long COVID in medical records. So I can't give you an exact time, because I think it varies.
I think also clinically, as a physician, take care of these patients, it doesn't really matter, right? They start developing shortness of breath at 45 days, 90 days. It doesn't really, we're going to start treating that right away. And I think the official time period for it to meet either ICD-9 codes or to meet a study criteria is for that purpose. But clinically, we as physicians need to start to recognize those symptoms, ask for those symptoms. I was talking to a patient group the other day, and I said one of the most important things as a healthcare provider is to acknowledge the symptoms. And so many of these patients with long COVID, and I'll be interested to hear others' thoughts, really felt that they've not been listened to, that their symptoms have been denied. And so I think one of the first things is, we have to recognize that these symptoms that were in this study are really living proof that there is a entity called long COVID, and we now are starting to figure out why that is, but it's present, and we need to acknowledge that to our patients.
Okay, you've got to be seeing this in your world too.
We do get a lot of referrals to the infectious disease clinic for long COVID. But this is part of the controversy that we have all been talking about. Right now, there's really no active infection at this point to be treating. We are still looking for the mechanisms, as we heard. But this is something that is managed mostly by primary care and those specialty services to deal with those symptoms. So yeah, we still do get referrals and have other physicians referring patients to us for those persistent symptoms that occur, after that initial infection.
You guys are the research team and are the research experts. I'm in a field called administrative medicine. We wear really dark black suits and always come bearing bad news. But you all are really out there trying to advance the science here. And one of the things that feels like we have to go ahead and have a definition, because the power of research is not found in individual investigators or studies. It's found in with these large groups you all put together to help really understand complex problems like this. But we have to have a working definition to agree with. Is that fair?
Yeah, I think so. And the way we approached it, Steve, in terms of thinking about the studies is that everybody with long COVID is not the same patient, not the same cause either. We see some patients with brain fog. I see patients with shortness of breath. Somebody in physical medicine may be seeing somebody that's extremely deconditioned, from it. So those are very different patients. And so what we've started to learn is that there's likely different underlying causes of how the virus turned on our immune system to become hyperactive, and you start to see autoimmunity. Or perhaps that there's this persistence of the virus, or perhaps that there's damage to the lining of the blood vessels from the virus itself, the endothelium. So these are all different potential things that we can guide different treatment towards. And so that's how Recover is now moving into the next phase. Is we have now 4 studies planned. We have potentially a 5th study being developed that will target those different type of patients with long COVID with different treatments specific to that phenotype, to that expression of symptoms.
So we want all the answers today, so we help with these patients out there. But how fast do you think we'll get answers that will be meaningful to the daily lives of these patients with long COVID, team? Dr. Rosen.
Yeah, so I think the Paxlovid VITAL trial, which Mario referred to as one of the ones that your center is doing, may give us early answers. It's a short-term trial, and it really asks the question, is long COVID related to viral persistence? And if it is, can a treatment which we know works in acute COVID actually work in long COVID by reducing symptomatology and killing or removing the virus that may be hiding out somewhere? So I think at least one trial will give us early indications of the hypothesis that viral persistence is actually driving this immune response, as Mario talks about.
Yeah, that would be good luck. I hope that works.
Well, I think we have to have some positive, outlook on things in terms of when we look back, at least over my 3 decades, maybe a little bit more, I don't know.
It's more. Just stop. It's more, a lot more.
But when we think about, other viruses that we've encountered over our lifetime, HIV, hepatitis B, hepatitis C. We're on top of those viruses now. We're able to control them, thank goodness with Dana's group and others. We have treatments to restore normal life for these patients with those diseases caused by viruses. So I see that as kind of the future with long COVID, is that we're going to be able to have a treatment, potentially like those other viral infections, that we can restore patients back to normal.
That is the right outlook for folks, and I think we'll make that same difference for this as we did with Hep C and what we did with HIV. Dr. Rose, if I switch gears for just one moment, when the COVID public health emergency ended, it felt like some folks in government had an attitude of mission accomplished. Too early for a victory lap, do you think?
Yeah, no, I think that's the case. And I think that's one of our biggest battles that we're fighting, is recognition that it goes on. And those numbers are staggering, but they don't seem to have made a huge impact. I've been in Washington several times, and Susan Collins, our senator, has helped us insert money into one of the appropriations bills to add $5 million for centers of excellence in long COVID. But that's not nearly enough. And the administration and many of the congressional delegations want to forget about this. And our patients can't forget about it. And we can't allow the powers to be to forget that we really need more resources. We need more exploratory studies to understand the pathobiology of this disease, and we need more trials. So I think, unfortunately, as it's waned, the acute COVID infections have waned, although they've not gone away. We're still left with a sizable portion of people who are suffering.
Yeah, I think that's right. I think we should fear the fall here. And I mean that both seasonally, for the fall coming, and of course symbolically, if we don't take action to make sure we save these folks in the long run. Hey, we're here to answer your questions about long COVID. Use the social media on your screen, Facebook, YouTube, Twitter, or I guess maybe we have to change that to the X. So X us or email the Medical News Network. Time for the COVID count with Doc Hawk.
Yeah, hi. So right now, COVID count, Steve, you know, the numbers had been low. They'd creeped up a little bit. They're a little bit lower now, so 9 total, only 6 active. Unfortunately, 2 in the ICU, 0 on the ventilator. I've seen 2 of those people in the past couple weeks. Certainly, they were here because of COVID. I think as we continue to move further, and this is something we've been discussing for the last year and a half or so, are they here because of COVID or with COVID? Again, we are only checking people with symptoms. So right now, we know that these 6 active at least, and a couple of them are really here, especially a couple in those in the ICU are here actually because of COVID. We know SARS-CoV-2 is still out there circulating. We hope the numbers stay low, but are always bracing for an increase in the number of severe disease and hospitalizations.
Yeah, and I know that overall the numbers may remain very low nationally, much lower than the last 3 summers.
Yeah.
With hubris comes reality, and we have to be careful because we know wastewater testing and numbers nationally are starting to show a little bit of a rise again. I'm going to jump now to Alexis Del Cid, who is standing by with questions from our community, because I'm going to suspect, Alexis, there are a lot of questions out there about long COVID.
Because so many people say they're having symptoms of it. So I've got a great question from Yen Liang, who wants to know, how do you avoid swollen finger joints caused by long COVID? Is that something you see often?
I'm going to turn to my endocrinologist.
I'm an endocrinologist, but you know, there could be an inflammatory joint problem if in fact the swollen joints are there, and this may be a post-COVID manifestation. We don't see, you know, we haven't seen a lot of this, but it's certainly something worth focusing on, and maybe, you know, non-steroidal or aspirin might help that. But that's an interesting complication. And again, you know, this is very classic for what we see in the clinic, that people come in with these somewhat unusual complaints that are not repetitive in a lot of people, but are part of the complex syndromes.
Yeah,
I would add. Yeah, I would just add to that to go ahead and make sure that patient gets a workup by their physician for autoimmune panel testing and so on, because we have seen that, as Dr. Rosen mentioned, where the virus kind of kicks the body into this pathway where they start to react to, the body starts reacting to itself, and it causes things like inflamed joints. So very important for them to get evaluated.
Just got a text from one of my friends who had long COVID. She and her whole family got it, and 2 family members suffered intense itching on their scalp. What would cause that? Because they didn't have it, but they both got it right after COVID, and no one could figure it out.
Again, it could be autoimmune. It could be that the system is driving that. Hair loss is a symptom that has been reported in the complex, in the 12-symptom complex. And this, you know, the itching may lead to hair loss, and there are probably a number of different variants of hair inflammation that might occur. So again, could be autoimmune, as Dr. Castro said. Our antibodies are being produced against something, a protein in the hair or hair follicle.
So I can't blame my wife and kids anymore. That's what that says. Got it. All right.
Joellen McGranahan has a question. She wants to know, a year from now, what could long COVID look like if you had a crystal ball?
What do you think?
Well, I would say that we're going to have a persistent reservoir of individuals who will continue to have fatigue, malaise, and post-exertional fatigue, almost certainly, and some brain fog. So there's going to be a residual group. How many of those individuals that currently have long COVID will get better? We don't know yet.
Yeah, I would just add to that that the pandemic's not, well, the infection is not over. COVID has not gone away. It's just gotten smarter. And so now the latest variants that we're seeing, XBB.1, are really out there in the community, still contribute to, unfortunately, cases of long COVID. Fortunately, we think that with the newer variants, there's less cases of long COVID that we're seeing, likely due to less severity of the disease. But it's still going to be out there for years to come. I think about the vaccine, and I'd be interested to see Hawkeye's thoughts about that, is that it's going to take a lot of work for us on an annual basis to kind of reanalyze, is the vaccine covering for the right variants that are in the community, and we may need to adjust things as we go.
I have one more question. Go on.
Sorry. Go ahead, Hawk.
Yeah, I mean, I think the question of the vaccine is, again, it has gotten so complex since the initial infections and then the vaccine, and then people with just recurrent infection or vaccine primary series and boosters. Luckily what we have seen is that although the antibodies may be evaded by any new variant to one degree or another, we still have really that most important set of immunity, and that's those T cells that really help us to get protected from hospitalization and severe disease. Right now we haven't seen the virus shift where that and that type of immunity becomes obsolete. So that is a good thing, but certainly we need to continue to watch and monitor. And as people are getting recurrent boosters or infection and reinfection, they will hopefully, build up that immunity. And who knows what this disease process is really going to look like in the next 3 to 5 years as well, especially when you have the younger populations who are probably going to be exposed to it from a very young age. At what point will it become even more like those common cough and cold coronaviruses that we've known about prior to this? So there will be a lot of things to be looking for in the next 3 to 5 years for sure.
One more question from viewer Maggie. Maggie says, I have a family member who had serious COVID, was hospitalized, almost didn't survive. That was 3 years ago. Presently, this family member sees 3 doctors at the health system. Is this going to be the normal for him from now on?
Well, it's just hard to know without a lot more information around that one, I suspect, Mario. It's the truth is that patients can have severe diseases from influenza and other things. This is different, and so comment on that for us, guys. This is different with long COVID. But for an individual patient like that, we would need to know a lot more about their history and how serious their illness was and what their hospital course was like, I think.
I agree. I agree completely, but I think this is more the norm of what we're seeing. We're seeing a difficulty with primary care physicians because we don't have all the science, and then the referral to other subspecialists. And so one of the things we really have to work on is a unified sort of multidisciplinary approach for individuals such as this one.
And did you guys, just to say, I know we see some long-term complications for influenza, etc. I've never seen anything like this in my lifetime. Maybe HIV, but beyond that, this is just different. Is that fair?
Right.
Do you guys feel that?
That's fair.
Yeah, I think it's been quite heartening for me to take care of these patients in the ICU and then see them, months later. Fortunately, some of these patients do go back to normal or near normal. I've had patients on a ventilator come and see me now 3, 5, 6 months and a year out, And eventually some of these patients are able to get off of oxygen, but it's a slow course, and it does involve multiple specialties, as you just mentioned for your question there. And I think that's because, as Dr. Rosen mentioned, we need kind of all our best minds to get together and really help that patient. And so it does require a multidisciplinary approach. And I'm heartened by Dr. Rosen's comment about, Congress putting some more money towards that, because obviously this is not a problem that's going to go away, and we're going to need all the best minds together to handle this for our patients.
Huck?
Yeah, and I'd like to hear Dr. Rosen's comments too, but there is one, I think, group or population of patients that does feel more validated with long COVID, and not really happy, but more validated, and that is that group of ME/CFS, or what we know as chronic fatigue syndrome patients, who have for years been going through this now. And we get more and more information. Is there more information that it's linked to a certain infection at this point in time as well? But a lot of the long COVID patients seem to manifest and have similar symptoms and prolonged symptoms, just as those ME/CFS patients as well.
Dr. Rosen,
Yeah, I agree. I agree completely, and I think they've come out of the shadows, and the physicians have come to realize that this could be a post-viral thing, just like long COVID could be, and that these symptoms are real, and that we need to listen to that.
Back at the very beginning in medicine, I remember when I was at the University of Rochester as an intern or as a medical student, the history is still the most important tool that we have. And when a lot of patients tell you they're fatigued, there's something going on. All right, so final thoughts. Dr. Rosen.
Yeah, well, I think we're making progress, and your center is leading the way. You've got some of the best people, and you've got the clinical trials, and you've got the science behind you, particularly in pulmonary. And I think, there's hope down the road. I think greater recognition and greater education for primary care physicians is really, really important. We don't have a toolbox for primary care docs. What do you do? How do you do it? What do you expect to tell the patient? So I think those are some of the things that we really have to work on.
Yeah, I think that's exactly perfectly said. It just feels like that's been true for us over generations, and for some of us, many generations here in medicine.
What do you say? You always say we're building the ship as we go?
We build the airplane while we fly it, and still under construction. Speaking of which, I think final thoughts for you, and I think we've got your QR code.
Yeah, that'd be great if we can put up the RECOVER study. So we are enrolling into the long COVID study called RECOVER. And this QR code there and contact information, you can reach out via email or phone. And the reason this is important, because as we enroll into this long COVID study called RECOVER, that's going to feed our subsequent treatment trials that we're rolling out here. And so, get involved, contribute to the science. We say show me the science, but I would also argue I want my patients to participate. I want them to contribute to the science, right?
Show us the science.
And show us and help us, solve and tackle this problem. And so I encourage, volunteering for a study is always a little bit more extra work, a little bit more extra time, but it's so worth it. I've heard it so many times from our participants that I learned more about myself, Dr. Castro. I learned more about what was happening with my body. And so it is so valuable for you to participate.
Huck.
Yeah, I want to thank our guests. We know long COVID, post-acute COVID is so important. There are so many people that are affected by it on a daily basis. We are continuing to ask the questions and look for answers, and again, thanking our guests for help leading the way in doing that.
We knew one time that HIV was a deadly, tragic, and stigmatized disease. Hep C was once a deadly, tragic, and stigmatized disease. We know that COVID is now a deadly, tragic, and unfortunately in our society, often stigmatized disease. Faith, hope, and science, though, have led to abilities to manage and even cure HIV and hepatitis C. So let it be so for this, because it is the combination of our faith in each other, our working together and being a part of this science, and our hope that we can work that out so we can make sure that tomorrow is better than today for all of our patients and for all of you. Thanks to everyone for watching and or listening. Faith, Hope, and Science. We'll be back next week.
Coming up Friday on the Morning Medical Update.
Hey, how are you?
Oh my goodness.
Sue Flock came face to face with the stranger who saved her life. I'm Jessica Lovell on the next Morning Medical Update. Millions sign up to donate bone marrow, but only a fraction actually make the donation. Meet one hero who followed through. Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.